Thank you. Thank you. So I don't have any financial interest in this, whatever has been shown over here. And I will be speaking on counseling and pre-operative workup for excelling in premium cataract surgery. So it's not a premium IOL, but definitely all the surgeries are premium nowadays, and they are in the category of refractive surgery. So, but to be more precise and to focus on the specific kind of lenses or specific kind of surgery, usually it includes a presbyopia correcting IOL like multifocal, bifocal, trifocals, astigmatic correcting IOLs like toric IOL, and combination of these like toric multifocal IOL. And it has now gained increasing popularity because the number of patients are asking for such IOLs have increased tremendously, because a lot of cases have come enrolled into the public, and now more surgeons are prepared to implant because they have excelled in their surgical technique, and they all have these gadgets available with them that they are prepared to implant mentally and clinically also to these premium cataract surgeries. Essentials are that we should understand the expectation of our patient. This is one of the primary thing which has to be addressed and which has to be seen. A careful patient examination, not the ocular examination alone is required. We should look for any systemic condition. We should look at the gait of the patient, head position, and contralateral eye. Everything has to be seen. And a proper patient counseling, this is the key for the success in any premium surgery. A complete preoperative workup should be done. A careful patient history should be elicited. What is the previous history? What is the systemic history? What has been there? Is there any history of trauma or anything else? Everything should be elicited and should be taken into account. We should look at the age of the patient. Younger the patient, the problem of glare halos are more, and they get annoying effect due to this, and maybe at times in younger patients we have to explant. If your counseling is improper in younger age group patient, then it becomes sometimes it becomes difficult, and initially you should not address the younger age group patient for a multifocal IOL surgery in your initial period of practice. In males, it is because they are more prone to outdoor activities. So the females, housewives, are the better candidates to start with the premium surgeries. And profession. If they have a driving profession or a profession which they are not dependent on the driver or the chauffeur, or some of the officers, they always have a chauffeur. Even at young age, we can suggest these multifocal bifocal IOLs. We should always underpromise and exclude patients with some unrealistic expectations. And lastly, we should discuss the potential downside associated with these premium IOLs to the patients beforehand. A complete ocular examination of both eyes is mandatory. Corneal topography, placido and sham flow imaging should be done. Tear film assessment and Meibomian gland assessment, all this should be taken care of and seen thoroughly before taking the patients for surgery. Now, a new normal is to do OCT macula in all these cases, and I do it whenever the media permits, or maybe we can do it for the other eye. Check for glaucoma and other optic nerve abnormalities, IOL power calculation, keratometry, and axial length measurement, and using the right formula for the specific patient in high or low powers specifically. Do keratometry on nascent or untouched corneas. Or you can call the patient again if you are having some doubt. When measurements differ between two devices, do a third measurement with another device, or you can repeat on the same device which you are having. If you don't have a third device on a later date, maybe we can do it with Verion, we can do it with Pentacam, we can do it the IOL power calculation with other machine, and keratometry with other machines. Do not proceed if there are discrepancies in axis and magnitude. And inadequate tear film can impact preoperative measurements and visual outcomes. So this has to be kept in mind. Optimize ocular surface before ordering an IOL, specific IOL, and planning the surgery. Planning multifocal IOL in dense cataract is a challenge. There we should look for any history of systemic disease or any trauma. Bilateral IOL power calculation should be done in all these cases to avoid amblyopia. Other eye fundus and OCT examination if it is possible. Type of cataract, if it is hypermature with shallow anterior chamber, we should anticipate the proper IOL position. This might change in such cases. So the IOL power calculation varies in such cases. Be doubly sure of the IOL power to plan multifocal IOL in such an eye. Tear film assessment, look at the dry eye, do the Placido test and see. Look for the Meibomian gland dysfunction, as I said earlier. Epithelial basement dystrophy should be treated, or in such cases, we should avoid Salzmann nodule. One on the right side is a confluent nodule, and similar corneal opacities, if they are present, peripheral degeneration or pterygiums. All these things, even a small pterygium at the periphery can change the Myers and induce astigmatism. New normal OCT macula. I remember many cases which I have not done IOL because they had ERM, they had early ARMD, they had the early CME. This is interesting case with the rule astigmatism. Usually the posterior corneal surface has the opposite astigmatism than the anterior corneal surface. In this particular case, both the anterior and posterior corneal surface, they were having with the rule astigmatism, which was unusual, and we decrease the with the rule astigmatism usually as per the norm. But in this particular case, so what I meant to say is the proper calculation of the posterior corneal curvature and the power is very, very helpful. Actual calculation is helpful in selecting the right patient and avoiding this surprises post-operatively. Counseling in all sense should be done before the surgery. Explain possible conversion to routine monofocal or non-toric IOL in challenging cases like advanced hard-brown cataract, etc. Explain associated risk in posterior polar cataract cases, pseudoexfoliation, corneal opacity, uveitis, or any other history of trauma, whether ocular or any head trauma. With a mature or dense cataract, when we are not able to ascertain or see the retina properly. So these things should be taken into account, and inform the patient beforehand. A written consent should be taken, information should be given in writing. That is very, very helpful in court of law also, because patients forget all these things which has been counseled before when they come again. Avoid multifocal IOL in diabetic retinopathy, retinal veno occlusion cases, ARMD, maculopathies, retinitis pigmentosa, choroiditis, etc. Family counsel might be appropriate, and it is necessary to encourage questions from and ask beforehand. Meeting of a surgeon with the patient before surgery and during our surgery also, if you discuss or talk to the patient, is the contact. Conclude just 10 seconds more. Post-operative surprises are avoided, patient satisfaction increases, and grievances avoided by proper patient selection, complete pre-operative counseling, and always be firm to say no when patient's ocular condition is against, but patient is willing for premium IOL. Be prepared to address any residual refractive errors. Thank you.